Good afternoon, everyone, and good night to Dr. Liu. Good morning to Dr. Tang, people from all over the world. Nice to see all of you. And I think we are on time, so we'll keep the session on time, and I would invite the chairpersons to start the proceedings. So I'd like to invite Dr. Jagannath Dikshit, who is a senior oncosurgeon, Dr. Subhash Chawla, a senior laparoscopic surgeon from MMU in Ambala, and Dr. Neeraj Zamija, a senior consultant laparoscopic surgeon from Sir Gangaram Hospital, Delhi. I would request everyone to keep in time and would request the chairpersons to please invite the speakers. Thank you.
Thank you, Dr. Bindal. I welcome all the chairpersons. And to start the session, we have Dr. Roxanne Liu from USA. He's from Alta-based Summit Medical Center, and he'll be speaking on robotics in abdominal wall reconstruction. So we'll start with no delay. Over to you, Dr. Roxanne.
All right, let me share my screen. Thank you for the invitation. I want to thank the chairpersons for this session. And Vivek, it's actually a nice, bright, early morning. It's 1:30 a.m. right now in Alamo, California. So my topic is robotics and abdominal reconstruction. I'm going to get right into it since I want to make sure we run on time. These are my disclosures. I am a speaker for Intuitive Surgical, and I receive honorariums for them. And I do teach their advanced complex abdominal wall reconstruction courses. So I just want to first define abdominal reconstruction, and more specifically, what modern day abdominal reconstruction, in my opinion, is. And that's really just, the goal is to restore the abdominal wall envelope through tension-free repair using component separation and wide mesh reinforcement with minimal fixation, okay? And I think that component separation is what differentiates abdominal reconstruction from just a standard ventral incisional hernia repair. And for a larger incisional hernia like this, usually that involves defect closure, and if the defect is smaller than the separation of the rectus muscle, reconstruct the midline by reapproximating the linea alba. And the posterior or anterior component separation can be performed. TAR, since its introduction in 2012, has become very popular, especially with minimal access surgery. And then macroporous mesh is placed in the extraperitoneal position with wide mesh overlap. And because of the wide mesh overlap, there's little need for fixation. The results have been pretty consistent. Of course, some of the higher volume centers maybe are getting better results, but in general, open wall reconstruction gives you a deep SSI, surgical site infection rate of about 10 to 21%, mainly due to the large incision and the wound complications as a result of it. And the length of stay is about 7 days, although some centers are reporting length of stay of about 5 days, but none of the publications show any length of stay anywhere close to 1 to 2 days. You know, with laparoscopic surgery, the incision is much smaller, and so laparoscopic surgery for smaller incisional hernias and smaller ventral hernias has become very popular, but it remains limited in abdominal reconstruction for several reasons, mainly due to the physical challenges of operating in difficult positions for several hours. Some of these ab wall reconstructions can take 4 to 8 hours, which is quite physically taxing. Furthermore, it's technically very challenging to close a defect that's on the roof, perform a myofascial release, and create a big enough extraperitoneal pocket to place a large piece of mesh or wide mesh overlap. So as a result, when you start talking about larger incisional hernias, the minimally invasive repair with laparoscopy ends up being an IPOM with a bridging mesh, meaning the defect's not closed, and lots of transfascial sutures are taxed to secure this intra-abdominal mesh. So how does robotics change the equation? This is the 4th generation Intuitive XI robot that I currently use. Just as a reminder, the first 3 generations were based off of a platform meant for cardiothoracic surgeons. This is the first platform, first generation, to be specifically designed for general surgeons and intra-abdominal work. So for me, this is probably the most important point that I want to hammer which is robotic surgery is not just laparoscopic surgery plus wristed suturing. When people think about using the robot for incisional hernia repairs and complex abdominal reconstruction, they think, well, the wristed suturing is where the advantage is with robotic surgery. I would like to think of robotic surgery as miniaturized open surgery on steroids. And the reason is because not only is there needle driver wristed, but both the graspers, scissors, and if you want to use other devices such as vessel sealer and the stapler, they're all wristed. The suction irrigator is wristed. And also, just as importantly, there's tremor filtration and motion scaling. And that's important because you're operating in 3D at 10 times magnification. So things are really magnified. And the precision of the instruments with the tremor filtration allows you to work at incredible precision, which is what allows us to perform abdominal reconstruction robotically. And also, unlike laparoscopy, you're in a seated position. It's very ergonomic, and it allows you physically to perform these operations without feeling like you have to wait another month before you perform the next one. And then also, since you're controlling the camera and 3 instruments, essentially your assistant has the same level of training as you, thinks just like you, and is just as handsome as you, because it is you assisting yourself, which is the most incredible assistant you can have, okay? And this is what I mean by minimally invasive open surgery on steroids. So this is a patient who has an intra-abdominal mesh already, has a recurrence. And you can see, even though this is a piece of coated mesh, in ab-wall reconstruction, we frequently deal with situations like this. With robotic surgery, with the 10 times magnification and the ability with wristed instruments to attack the tissue at any angle I want, I can follow more natural tissue planes. My 2 hands really can function like my own hands, but just miniaturized in the abdominal cavity. And the dissection remains bloodless. I'm more likely to be able to see the plane between the bowel and this piece of mesh. And in this case, this patient has a lot of small bowels stuck to this piece of mesh. And as you know, enterotomies are the main reasons for perioperative complication, and enterotomy increases the perioperative complication by 3 folds in general. And to take that level of precision even further, this is an ETEP operation where I'm working the midline right now, taking down the peritoneum, performing the preperitoneal dissection. And you can see this layer of tissue I'm taking down. This peritoneum is transparent. It's 2 or 3 cell layers thick. And because the peritoneum lines the entire abdominal wall, I can actually perform this task across the entire abdominal cavity if I wanted to. And that's the level of precision that the robot affords. And all this is happening on the roof. Just remember, it's happening on the roof, which is not an easy task, let alone trying to peel this thin layer of tissue off of the abdominal wall. Robotics also excels in small spaces. ETEP is becoming more and more popular, and robotics is, it seems like it was designed for ETEP. It's also great for closing very large defects. Since we're talking about abdominal reconstruction, we have to be able to reapproximate large defects. And this is a defect that's about 25 centimeters long and I think about 12 centimeters wide. As you can see, I'm suturing with ease. Of course, this video is sped up, but I have about 4 sutures in the abdominal cavity at one time, and I'm managing all these 18-inch sutures and reapproximating a large defect. And if that's not ergonomically good enough, I can also use software trickery and invert the image and suture like I'm suturing on the floor. So I'm suturing on the ceiling right now, but I've inverted the image and swapped the 2 arms. And transport yourself to the surgeon and imagine yourself closing a laparotomy incision from left to right. That's what this movement replicates. So instead of suturing on the roof, it feels like you're suturing and closing a laparotomy incision, which is a very natural movement. So instead of thinking of the abdominal wall as just a single slab of tissue used for transfascial sutures and mesh fixation, Now, minimal access surgeons think of the abdominal wall like open surgeons do. There are many components, many spaces that can be connected and released and advanced. So in looking at the retrorectus space, the craniocaudal tunnel, the retrorectus space, we can combine it, just like in the open reef stopa repair. In minimal access surgery now, we can combine this space with little incisions and place a nice piece of mesh for midline incisional hernia repair. And if that's not adequate, we can perform a bilateral TAR and a top-down TAR and get into the flank spaces and into the subdiaphragmatic spaces. And we're not limited to the midline. We can also fix flank hernias, right, through a TAR and place a larger piece of mesh, right? So now we can release components to close larger defects under less tension and place large pieces of mesh. And I can put in a 30 by 45 centimeter piece of medium weight macroporous mesh through an 8mm incision. And so at the end of the operation, I don't have any incisions that are larger than 8mm. And not only that, we can perform quite complex tasks with the robot. So in the left upper quadrant, again, it's another large incisional hernia that I'm going to repair and completely reapproximate the defect and reconstruct the midline. In the right upper quadrant, you see me stripping the diaphragm, and this is a large left flank hernia where I want really good overlap under the diaphragm. And you can see through the diaphragm muscle, the lung moving with each breath, which is a pretty incredible view that general surgeons usually aren't used to. In the left lower quadrant, you see a video of composite mesh being removed, a 10 by 15 centimeter composite mesh. So, you know, due to the size of this mesh that I have to remove, I will have to make a small incision. So this would be considered a hybrid operation, both open and robotic. But you really derive the same benefit of robotic surgery. Patients don't have much pain with a small extraction site and can go home just as quickly as pure robotic surgery. This patient in the left lower quadrant went home on postoperative day number 1. And then probably one of the more complex operations is repeating a TAR or redo TAR, or Mike Rosen likes to say retard. So this is a patient who's had a bilateral TAR, developed a mesh infection, had the mesh removed, and of course developed a big recurrence. And I'm repeating a TAR. And again, the benefit is minimal access, 6-8mm incision. And this patient also went home the next day. Of course, robotics has limitations in abdominal reconstruction. Very large defects still require open surgery, especially ones where there's loss of domain. Need for extensive skin and soft tissue excision. More and more of us are performing hybrid operations, and maybe there's benefit in performing the soft tissue excision open, but doing the rest of the operation robotic. And when it comes to intestinal fistulas, infected mesh, and frozen abdomen, I think we're still doing open surgery just because it just currently doesn't make sense to fix these robotically. So in summary, robotics is a powerful tool to enhance and expand your hernia practice, and it really enables true abdominal reconstruction through minimal incisions. If you like my videos, I do have a YouTube channel. Just search Dr. Roxon Liu. I have lots of robotic hernia repairs on it. Thank you very much for this opportunity.
Thank you, Dr. Roxon. It was indeed a very well presentation, and with the robotics, we have increased our horizons to reach all aspects of the abdominal wall in repairing the complex hernias. In the interest of time, we will have the discussion maybe later at the end of all 4 presentations. I'll request Dr. Jagannath to please call upon the next speaker for us. So please unmute yourself, sir.
Next speaker is none other than Dr. Vivek Bindal, and everyone knows, you know, he is the Vice Chairman of Bariatric and Minimal Invasive Surgery at Sri Gangaram Hospital. Sir, over to you for your presentation, sir.
Yeah, thank you so much, Dr. Dixit, Chairpersons, and INDO-UK SURGICON for providing us this platform. and this opportunity. I would sincerely like to thank Dr. Liu and Dr. Tang, who in spite of time zone differences have been able to spare time, especially Dr. Liu sitting at 2 a.m. in midnight at his place. So robotics in bariatric surgery, I think we had a very nice live demonstration of a sleeve and a Roux-en-Y gastric bypass this morning by a robot, and a lot of things were covered, so I'll be pretty quick here. This is our hospital, Sir Gangaram Hospital, where we work in, and this is the kind of excess baggage that we see even in our country. So our country has been traditionally poor, but now we used to think that we'll not find obesity, but we find a lot of obesity and a lot of super obesity as well. And the reasons all of us know is our lifestyle. Our, we are just taking escalators and treadmills are being used by our dogs. So what are the challenges in bariatrics? In super obese people, we have huge livers, we have limited working space, there is a huge torque on the instruments, the comorbidities are severe, and the anesthesia is high risk. These are the kind of abdominal walls that we are dealing with. This is lipodystrophy of abdominal wall, huge torque, and that was a rich guy, and this is a poor socioeconomic strata person. Again, 70 BMI, huge abdominal wall, butcher by profession. A child, so they were all adults. This is a child, 152 kilograms, studying in grade 10, and his brother was 120 kilograms. So we are finding it across the spectrum, young, old, rich, poor. This is a lady with 85 BMI who actually came with CO2 retention and crash and casualty, and she had to be taken up as a very high risk case. Another patient of 80 BMI. So all these patients require something which can help you out, and that is where the robotic surgery comes in. This is the typical port position of a robotic bariatric procedure, which is not very different from a laparoscopic procedure. So we basically put in the camera port to left of midline. We use R1 and R3 to the left side of the patient, and R2 is used from right side. There is one assistant port and one for Nathanson's liver retractor. And the major difference in a gastric bypass is that we do a hands-on gastrojejunostomy in a robotic gastric bypass, while we do a stapled anastomosis in a laparoscopic gastric bypass. So this is how the patient would look like after the ports are inserted and the docking is being done. And after the docking is done, the assistant is standing by the side while this is the SI platform that we use in our OT. So there are revisional surgeries where robot has benefit.
This is an educational video from.
And this is one of the videos where the lady had got a vertical banded gastroplasty done via open method, and now she has dysphagia. So all of us know there are difficult cases. There's a narrow tube, upper GI endoscopy as well as gastrography shows a very quite a narrow tube there with a outlet narrowing of the VBG pouch. So as Dr. Liu showed, the complex adhesolysis is quite well done in robotics. So we did some initial adhesolysis to put in the ports, and then we docked the robotic system, which came in from the head end. And then robotic scissors is a very nice instrument to dissect, and because of the better vision you get on the console, you are able to dissect well, see well. And here we are separating the stomach pouch from the liver. So in VBG, what happens? People place mesh around the stomach pouch, and it gets densely stuck to liver and surrounding tissues. So after we have identified, now this is the line which is showing the VBG pouch, and on the other side we can see the remnant stomach. So the idea is to connect both of them. Sometimes we convert it into a Roux-en-Y gastric bypass, but here the lady didn't want any further weight loss. So the idea was to revert this to normal anatomy. And here we have done the gastrostomy. And you can see the bougie. So this bougie is coming in through the esophagus into the lumen of the gastric pouch, and this was the septum. So what we are doing is we are simply disconnecting the septum. So the remnant stomach is now one with the gastric pouch, and that is going to relieve her of dysphagia. So we are just suturing for hemostasis, and then we suture close the gastrostomy. Again, suturing with robotic system, especially in super obese patients, is much easier as compared to laparoscopy. So here in these kind of revisions, robotic system actually helps us do a much better job. This lady did well, and this has been few years that we did this particular case. This is another case of robotic sleeve to SADI. So this patient had undergone two procedures, one gastric band in 2006 and sleeve in 2012. And now he is again back to around 150 kilograms with 48 BMI. So we planned a SADI-S, that is a single anastomosis duodenal-ileostomy. The sleeve was not much dilated on gastrographin. So this is the port position, and here we are taking two arms from right side of the patient. These kind of patients have pretty huge torque, and we have to basically do a duodenal-ileostomy. So we take marking stitches for marking the bowel, and then we dog the robo. So we basically do the duodenal dissection and make a retroduodenal tunnel. And so these endo-wristed instruments help us make it. The stability of the platform is very helpful. And then we have decided divided the first part of the duodenum. Now we are going to bring up the bowel, and we are going to do the duodenal-ileostomy. And this is the portion where robotic system helps us a lot. So we do a 4-layer hand-sewn anastomosis, and using the robotic system, we are able to throw stitches in a very nice fashion with a lot of precision. Our left hand also works very well. This particular patient had a huge amount of torque, so it would have been very difficult to do the same thing laparoscopic. So this is the enterotomy and the didnotomy. Robotic hook is again a versatile instrument. It gives a very nice angle to open up bowel here, and then we extend the enterotomy using harmonic scalpel. And this is another barbed suture which will do the second and the third layer of the anastomosis. So it is pretty much same to what we showed in the robotic gastric bypass this morning. The principle of anastomosis remain the same. We do a 4-layer hand-sewn anastomosis. So this is the posterior wall being taken. With the robotic system, it takes away all the torque, and whether you are operating on a 50 or a 60 BMI, there is not much of a difference as far as the surgeon goes. The difference is taken up by the system itself. So this is the completion of the third layer. And the anterior-most layer is completed. So this basically, I showed these two videos to show how robotic system helps us in doing dissection and reconstruction in revision cases. This is an article which we published comparing robotic bariatric procedures in morbidly obese versus super obese patients, and we found there was no difference in complications in spite of the BMI being more in super obese. This was an article in obesity surgery on technique evolution, learning curve, and outcomes of 200 robot-assisted gastric bypass patients, and we found that there was 0 leak and 0 bleed rate in these 200 patients, and the learning curve was around 50 cases. This was the article which we published on robot-assisted duodenal gastric bypass as a reoperative procedure. So 32 patients done reoperatively without any leak or any major complications. So I think robotic system does add to our versatility. This is the review article which we published on role of robotics in bariatrics, And considering all the published literature, it is seen that robotics is safe and feasible and provides specific advantages in super obese or revisions. This is a recent meta-analysis published in Obesity Surgery, which shows robotic surgery has a longer operative time in bariatric procedures. However, there is a decrease in the anastomotic leak rates, which is a very, very important finding. And also this another meta-analysis in surgical endoscopy, which shows that after correcting for all the factors, the robotic approach is associated with better post-operative outcomes, especially for Roux-en-Y gastric bypass. So we also believe, and with a lot of new platforms and new systems coming in, I think we are going to get better. So ICG cholangiography, a lot of us have been using. So in the assessment of stomach vascularity, this is a video which shows the ICG cholangiography after reconstruction, while reconstructing after an esophagectomy, and you can see the ICG is making the stomach green while this portion of stomach is not lighting up. So this is the non-vascularized part of the stomach, while this is the vascularized part. While on normal light, it is everything pink. So it would potentially help you prevent any kind of anastomosis through a non-vascularized part. This is how the OR of the future may look like. So in summary, robotic bariatric surgery is safe, feasible, and effective. Robot assistance helps overcome difficulties encountered in super obese, and ergonomic comfort to surgeon is there. Ease and precision of gastrojejunostomy is an advantage. It is a good idea to start with robotic sleeves before going over to gastric bypasses. And we strongly believe that robotic surgery training should be inculcated in residency and fellowship programs. Thank you for your kind attention. I'll be happy to take any questions.
Dr. Vivek, excellent presentation. I think all the important things you have shown us, and we also saw your live surgery in the morning session. Very comfortable, very confident, and everything went very smoothly. If any questions, I think I think you finished on time. If any questions, we can take up. Neeraj, anything from your side?
So, do you always use this hand-sewn technique for these complex anastomosis, or you have compared some stapler also with the hand-sewn about the outcomes?
So when we use robotic systems, we have typically just done a hand-sewn anastomosis, and we have not done a comparative study because we strongly believe that hand-sewn outcomes are better. The staples would permanently stay there, and although they are said to be inert, but they cause some kind of chronic inflammation. That's why there have been publications which show a less stricture and less ulcer rate in gastrojejunostomy after a hand-sewn anastomosis versus a stapled anastomosis, whether done laparoscopic or robotic. So we always do hand-sewn. Yeah, we have not done that study ourselves.
Okay.
Dr. Liu, if you are there, I would like to ask you a question, considering we have 1 minute left. So what do you think is the best approach for a TAR done robotic? Like, you should start with transabdominal approaches, or if somebody is already doing endoscopic ETAP TARs, he should just replicate an ETAP TAR into a robotic ETAP TAR?
I always try to perform the surgery via ETAP first. The person has a nice wide rectus muscle, good retrorectus space, and the retrorectus space hasn't been violated. I like putting my ports into the retrorectus space just to avoid having to deal with adhesions early on. And going transabdominal, sometimes you can't put the robot ports in early, or doctor robot early, just because you have to do a lot of laparoscopic lysis of adhesion, and robotic lysis of adhesion is much easier and safer than laparoscopic lysis of adhesion. And with the ETAP operation, I can go from the one retrorectus space to the suprapubic space to the subxiphoid space, and then over to the other retrorectus space before getting into the hernia sac. And then I could potentially take down the entire hernia sac without getting into the abdomen. So that I always try that, but most of the time I fail and I go into the abdominal cavity, which is not a big deal. So I like to start ETAP. I think it's a better way, but you have to be very comfortable, of course, extraperitoneally moving through the abdominal wall.
Thank you so much. Thank you so much.
We have got another chairperson, Dr. Subhash Chawla. Sir, can you call the next speaker, sir? Sir, you have to unmute. Yes.
Okay, I have unmuted now. Hello. Thank you, Dr. Vivek. You have presented very well. I congratulate you for your recent international publications and today conducting CRSA virtual conference also. Now I invite my next speaker, Dr. C.N. Tang from Hong Kong. He is a fellow College of Surgeons, Hong Kong, FRCS Edinburgh, and he is a chief of service surgery in Pamela Yard Eastern Hospital, Hong Kong. Dr. Tang will be speaking on robotic pancreatic surgery. Now I hand over to Dr. Tang for his deliberations.
Thank you very much. Really glad to receive the invitation to deliver the talk on robotic pancreatectomy. I hope you can see the slide well. And I think pancreatectomy is demanding, and whatever type of surgery removing pancreas, you have to prepare yourself. We have gone through 2 decades, and starting from 1999 with the first laparoscopic pancreatectomy until 2009, we start embarking on the journey on robotic Whipple and also other robotic pancreatic surgery. Since then, that would be the standard of treatment in our institutions. And I think there would be a lot of pros and cons regarding robotic surgery. I think the most important thing would be enhanced suturing capacity with the robotic approach and also better visualization. Of course, an expensive installation, also expensive consumable would be the one that could possibly deter surgeon thinking about this surgical approach. And robotic pancreatectomy, we need enhanced visualization, immersion image, surgeon control, and then obtain the optimal modification together with improved laterality, and that would be pretty crucial for whatever pancreatectomy. But never forget about ergonomic consideration for surgeons, and so that we can prolong our surgery life longer. And even though at the moment there's still a lot of controversy whether MIS pancreatectomy is definitely better than open pancreatectomy. And this is a review article in comparing open versus MIS pancreatectomy. I think the operative cost for MIS pancreatectomy is definitely higher, but with lower post-operative cost. And both procedures are considered to be equally cost-effective. And robotic education, I think this is a very simple procedure, but fine dissection is required. And robotic ultrasound, once again, will give you a very good localization as well as define the relationship between the tumor and also the MPD. And this is a hyperlink and showing you what we can expect for patient. This is a patient with previous trauma, and he sent with endocrine tumor in the tail of pancreas. And initially, we found something there, but this is turned out to be accessory spin, and secondary to previous trauma to spin. And on further dissection, we just remove it, and then doing the ultrasound and dissect, and confirm there's a lesion right there. And with ultrasound, able to show a tumor just measuring about 7.7 centimeters in size at the superior border of pancreas. I think the rest of the procedure is trying to excise it from the left pancreatic parenchyma. And this is how we are doing largely, and there would be a very good pain demarcation separating the tumor from the rest of the pancreas. And patient usually recover quite speedily after surgery. And distal pancreatectomy would be not really demanding in terms of we don't need to go through reconstruction. And laparoscopic surgery is gaining popularity, and particularly for those no-risk pathology. And there's still a big controversy regarding how we apply this technique for bank malignancy. There's also a tendency of high vessel perturbation for splenic perturbations, and with the robotic approach. RAMS is technically feasible, but very limited evidence at the moment. I think whenever we are doing this approach, we have to adopt extra caution and applying the robotic approach for RAMS procedure. And this is the medial to lateral. I would like to show you the lateral to medial, and this is patient is basically put in lateral position with a very gentle dissection, go through the gastrointestinal ligament and identify all the vasculature, and we start to see the very key visualization of the pancreas, and we dissect from the tail, lateral to medial, with the ultrasound confirm the cystic euphemism and also mark the demarcation line where we are going to transect the pancreas. And this is the part. We go through one by one, able to see all the splenic vein and also splenic artery quite well, and separating it. And very decent dissection without too much bleeding, and then you have such a wonderful medication and also dexterity conferred by the robotic systems. And again, we got the robotic data going with the XI machine, and the last step is basically to transect it and identify, see whether there's any bleeding and also potential fistulation at the transection end. And I think this is a lateral to medial approach. Pancreatical duodenectomy is much more complicated, and there would be theoretical advantage of easier pancreatical and anterior anastomosis, but not really supported by evidence. There would be marginal benefit, and there might be a little bit less operative loss and also start faster recovery compared to open and also laparoscopic approach, but not sure whether that marginal benefit would justify the expensive installation and also recurring costs for the robotic systems. And another question is we need to answer. And because surgeons doing laparoscopy and surgeons doing robotic surgery, they usually have different degree of experience. Whether we are comparing the approach or whether we are comparing the experience and also technique of surgeon practicing different approaches. And it's a lot of heroic surgery. We need teamwork, we need to engage all the stakeholders and also provide training and monitoring to ensure service sustainability. Once again, in order to guarantee good outcome, you need to standardize your procedure. This is what we call anti-clockwise approach. Cholecystectomy, cochlearization, gastrectomy, portal dissection, leg transection, DJ mobilization, and transition of and doing. Having usually a little bit of short while of coffee break before we go on to reconstruct PJ, HJ, and also GJ. And this is the usual proposition what we are doing. I think right now we're using all the 4 Chuka thought, but leaving the umbilical cord for the backside surgeon to do it, because give you a little bit of space and also allow surgeon to work free from the movement of robotic arm is pretty crucial. We also put patient in 15 to 10 degree reverse transcendental positions. And this is a typical robotic ripple procedure. We have complete the cholecystectomy and then going for the cochlearization, mobilizing the duodenum bit by bit until you are able to see the IVC and also anterior surface of the aorta. And we usually take the left renal wing as the landmark and also try to identify a bit of the roots of the SMA. And we also harvest lymph flow in the aorta cable window. If there's any involvement of that lymph flow, we usually stop the procedure because the disease is very long and localized. And right after that cochlearization, we mobilize all together, almost up to DJ pressure and mobilize it and towards the right hand side. And then after the cochlearization, we go to the gastrointestinal ligament and entering the lesser set and then transect the stomach with the endostator. And we usually do 2 endostator to transect stomach, and then followed by portal dissection. I think I routinely use the diaphragmatic hook as well as harmonic scalpel for all of my procedure. I think this is really essential so that you're comfortable with one type of instrument to help you to go for dissection. And GDA, we routinely control it with endostator because I believe this is a ratio that deserves special attention. And then to avoid the postoperative hemorrhage. And after division, we go for further dissection and clear the lymph flow along the common hepatic artery and also clear all the tumor involvement of the SMV and also portal vein. And after that, we dissect in the infrapancreatic area, identify the tunnel and separating the SMV and also anterior located pancreas and then transect it. I usually transect it with harmonic scalpel until I'm reaching the pancreatic duct. I use the scissor to avoid a cautery injury of the pancreatic duct. And this is my routine practice. And this is the part we encounter the pancreatic duct, which is not too small for this case. After the transection, we slowly deal with all the jejunal wing and then dissect out the asymptosis. Of course, I would thin it out after the transition. I sling up all the branches of the SMV and portal wing and also splenic wing to allow me to harvest all the lymph flow along the SMA. And this is my routine practice now. And this is the SMA origin. I key all the lymph flow around that area until I'm seeing a very good visualization of the SMA. And that probably I will stop the procedure. Anastomosis, I adopt a modified bone gut procedure, and this is how I'm doing the procedure. Basically, I apply 2 transpancreatic stitch and going through the pancreas, and then removing the jejunal limb and to bind the pancreas with the jejunum, and going back to the pancreas again and tighten it so that form the posterior layer. And another one inferior. After tightening of the superior and also inferior transpancreatic stitch, I go for the interrupted pancreatical ductal mucosa technique. I usually use a vascular fill, and this is a vascular suture, and I usually put about 12 to 15 stitches interrupted manner, and to approximate the duct of the pancreas and also the jejunum. And this is the last bit. After this, I go through the stitch again, and then cover the ductal mucosa and anastomosis with the serosa and also the capsule of the pancreas. This is how I perform the modified bone gut procedures. I might add 1 or 2 and interrupted stitches to augment the anterior coverage. And this is how I perform the surgery. Of course, there would be cases that might be bleeding from the branches of the SMA, and there might be bleeding from the SMV. And I think I would like to show you this short video. And basically, there's a jejunal branch coming off from the SMV because of a very short length of the wing and being controlled with hemolog upon a bit of suction manipulation with dislodge the hemolog, and then end up with bleeding. I press it for a while with the gauze and prepare everything like the stitches, and then go back again, and when I got the needle available, and then try to deal with it. The bleeding is quite excessive, and you don't have very good will, but trust me, with the suturing capability of the robot, we can deal with that bleeding without too much problem. Just a little bit of blood loss, and you can suture quite well without compromising the safety of the surgery. There are myths versus reality for robotic pancreatectomy, and particularly for robotic PD. And the myths are robotic PD is an easy operation, but taking longer time to finish. The post-operative outcome is much better, particularly for pancreatic cancer. I think there's no proven evidence, and this approach is much better than laparoscopy in terms of distillation rate, and also in terms of the operative time. And probably, I think I can do a faster robotic whipple than open whipple nowadays. Reality, I think we need to follow the surgical principle, and basically this is just the same. And we also need to have a learning curve for this procedure, usually about 50 to 60 cases. And if there's no obvious improvement of the outcome, but using this approach, I think it would be quite difficult to make it a very cost-effective treatment approach. Future improvement in terms of advancement in technology and also technique are essential to ensure popularization of this technique. And there would be a long list of publications. Most of these studies are basically retrospective cohort randomized studies, and basically showing you comparing to open, longer operative time, and faster recovery, less operative loss, and also sometime when patient can recover a bit faster and to have adjuvant treatment. I think the most important message from this and would be we use this approach, and hopefully we can have faster recovery and also safe outcome for the patient. But basically, there's only evidence of less operative loss.
Dr. Tang, please finish.
Sorry?
Please try to finish. Your time is up.
Well, and usually with a shorter hospital stay, but the outcome cannot justify the expensive cost of the robot. I think I would like to go to my conclusions, and the international guideline of MIPR going through the 6 area, and I think there's still a big gap in robotic pancreatectomy, and including laparoscopy and also robotic approach. And in the future, we hope there will be more advancement in terms of technology and also technique to make robotic approach will be a cost-effective approach for pancreatic surgery. I think that would be the end of my presentation. Thank you very much for your listening.
Thank you, Dr. Tang, for an excellent presentation, beautiful videos of robotic surgery, and it has shown that it's better than laparoscopic, and the way you have shown how to control the bleeding, it's very difficult in laparoscopy. Thank you very much. Since time is up, we will request for the next speaker.
We'll call Dr. Dr. Avinash Aklani, who is the robotic colorectal surgeon from Tata Memorial Hospital, and he'll be speaking on the role of robotics in colorectal surgery.
Hi, good afternoon, everyone. Thanks INDO-UK meeting and IAGES for giving this opportunity. Some great talks by Professor Tang and Professor Liu. I'll just share my screen and go on my presentation. I think the incidence of colorectal cancer in India is less compared to the Southeast or Europe, but however, the survival of colorectal cancer is very low compared to the West. And most of it because people present with locally advanced cancers. For my talk, I'll concentrate on rectal cancer, otherwise to compare whole colon and rectum is difficult. So normally for standard rectal cancer, chemoradiation is the standard of care, total neoadjuvant therapy is just coming in. So once you give chemoradiation, 30% of patients in India would still have MRF positive. So the options would be, if you have complete response, you go on wait and watch. If you have good response, you do TME. But 30% of patients where the margin is involved, you can have extended TME or beyond TME. If you want to do MIS for these patients, probably a robot plays a good role. Now this is an example of a standard TME. We'll concentrate on the pelvis. You can see good views, good control, and the dissection goes well. You can go as deep as possible if the camera is in your view. You go down to the pelvic floor till you see the levators. And you can see the V of levator, see the intersphincteric planes. A 30-degree up also gives us good control. This is important in high BMI patients. Following this, what we do is we do the anterior dissection. You see the seminal vesicles, and once you can cut the Denon-Villus fascia. And if you've done enough posterior and anterior dissection, the lateral dissection is not difficult. One of the things you can do is you can hold the Denon-Villus fascia very well with the robotic system. You can go down to the pelvic floor. Once you've done enough dissection, you can localize the tumor using endoscopy, and then you can, whether it's a TME or tumor-specific mesorectal excision, you can do a transection. You can see the hypogastric nerves here, the anastomosis is done, and that's the standard TME. But most of these are done through laparoscopy as well. But the next part we come in, at the tertiary center, we see a lot of extended resections. So if you remove the whole bladder or the uterus, then it becomes an extended patient. So it includes forming pelvic node dissections, urinary conduit, and plastic reconstructions. Whereas with extended TME in young patients, you may take a surrounding organ, seminal vesicle, prostate, pelvic node dissection. They have good outcomes. So we started in 2014, the first exercise system there, and we published the results. There were no conversions. Single phase colonic and pelvic dissection was done. It was done quite successfully. And we finished more than 100 cases. We looked at learning curve of robotic versus laparoscopy. So we compared early procedures of robotic versus laparoscopy and tried to look at outcomes. So the oncological outcomes were similar, but complications of robotics seemed less with sphincter preserving surgeries for the same learning curve. After doing more than 250 colorectal procedures, we decided we didn't do any. And we did a lot of extended dissections as well. We used standard format for downstaging. We used the same format for XI. Most of these are middle and low rectal cancers, T3 and T4. We had a fair percentage of PMI, which was less than 25. But as you can see, we concentrated more on extended dissection, high BMI patients, excentrations, and extended TME. And we found there was no difference in learning curve because we were already doing more than 350 to 400 laparoscopic procedures a year. I'll just try to go on some videos and I'll go back to the screen there.
This video demonstrates robotic abdominal perineal.
So this is an example of a neuroendocrine tumor where the tumor is touching the MRF and ischial spine. After downstaging with chemotherapy and cisplatin,
We begin the dissection by
then probably it requires an extended TME. So we do the dissection below the vein here.
Fascia from medial to lateral.
Here to access, even if you do extralevator APR, won't get wider margin. So for this one, we're going to do the procedure where we ligate the pedicles. We'll do lateral pelvic dissection on that side and then cut the levator at the level of ischial spine.
The root of the inferior mesenteric artery.
Here the IMA is being bad.
And clipped and divided.
We use the seagull sign, lifting the IMB and IMA and take the IMA at the root.
Further medial to lateral dissection continues along the mesocolic fascia.
Following this, we go in the mesocolic plane. You can see the genital fascia very well. The last part is we just push the lower part away to get iris maneuver.
Pelvis and the posterior dissection is completed. Till the
You go in the TME plane there. So the posterior dissection is done, and because you have to cut on the left side at the level of levator, the lateral cut goes after you mobilize the colon along the level of the iliac vessels.
By scoring the peritoneum over the iliac vessels.
Once you dissected the iliac vessel, the main landmark is to define the ureter. You preserve the ureterohypogastric fascia medially. Once you identified your landmarks, you dissect the iliac vessels, the external iliac artery and vein. You find the bifurcation of external and internal iliac vein. Medial to the external iliac, you can see the psoas. When you're dissecting the junction of external and internal iliac vein, you take the lymph node packet off and you can see the obturator artery starting there, and you'll see the obturator nerve as well.
As the dissection continues further, we are able to identify
defining the packet anteriorly, you see along the obliterated hypogastric, you go anteriorly. This is the communicating vein.
And divided. The nodal tissue along the obturator nerve is then dissected carefully.
This is the communicating vein between the external iliac and the internal iliac or obturator vein there. So the lymph node packet comes off. The next step is to follow the branches of internal iliac.
Umbilical artery.
You need to follow the internal iliac branch as well. We cut the obliterated hypogastric.
This is followed by
and the superior vesicle.
Artery. The remaining nodal tissue along the internal iliac vessel.
We free it medially as well from all sides, so the lymph node packet is free.
The distal end of the obliterated umbilical artery.
Obliterated hypogastric on the other side is also cut.
Clipped and divided. The remaining nodal tissue along the obturator nerve is then cleared.
So the part of dissection which is important is going along the pudendal and the inferior vesical vessels, which is likely to bleed. So you take it towards the head.
Dissection then continues further down along the internal iliac vessels.
So as you can see, you can define the branches of internal iliac, that is the internal pudendal which is going down. Lumbosacral trunk is seen well. This is important for extended dissections when you want to do lateral pelvic work dissections. So
continue further down.
The sacrospinous ligament is identified.
Serves as the landmark.
The pudendal artery will go below the greater sciatic notch and the lesser. The ureter is mobilized.
Then continues. Keeping
and you can preserve, you can do nerve sparing. You can see the hypogastric nerves very well.
The hypogastric nerve. As we continue with the lateral dissection, we also encounter.
And as you dissect, you can actually see the origin of middle rectal vessels from internal iliac.
We then continue with the dissection along the internal iliac.
So you dissect it down to the pelvic floor and you can do a wide excision of the levators. Anterior dissection is done standard. So what you want is finally a specimen like this. The highest point which you see there is actually the part which causes this. The other thing which can be done is excentrative procedures like this. It's a locally advanced cancer after CTR is still progressed.
Below the inferior
They're going to do total pelvic
The
exentration.
dissection then proceeds from medial to lateral. In the IMA
To
root
take the IMA at the root.
and the IMA is clipped and divided beyond the left colic artery.
We do the posterior dissection.
From further medial to lateral along the mesocolic fascia, followed by the posterior dissection. Lateral peritoneal cut is then taken and the descending colon is mobilized. We then continue.
And again, every part of the pelvic dissection, once you finish the posterior thing, you should do lateral pelvic node dissection.
We then begin the pelvic node dissection by scoring the
Similarly, there the external iliac
large
vessels.
difference is identified, clipped and divided. The dissection then proceeds along the external
Ureter is mobilized.
along the vesico-hypogastric fascia and the pelvic node dissection is completed. During this pelvic node dissection, the nodal tissue along the internal iliac vessels.
And once you've done pelvic node dissection, you start taking all the pedicles of the bladder.
The nodal tissue is then dissected out completely and the ureters are mobilized.
You can see the obliterated hypogastric being taken.
And divided.
Finally, by the inferior vertical
Into the
pedicles.
internal iliac veins are then clipped and divided as and when encountered.
Once you've taken off the pedicle, then you mobilize the ureter, transect the ureters.
Completely. Similar pelvic node dissection is then completed on the opposite side, and the ureters are clipped near the vesico-ureteric junction and mobilized proximally.
Then the cystectomy is performed, which is quite a relatively easier part to do. You go in the front part. Go anteriorly, you can take the TVC anteriorly here or from the bottom itself.
The urethra is then cut and the Foley's catheter is then taken out.
So any bleeding here can be controlled. And so once the rectum is transected, you can form a conduit intracorporeally as well. You find 20 centimeter above in the terminal ileum, you mark it. You form a 15 centimeter segment of ileum. You make an intracorporeal conduit.
The ball continuity
It's an intracorporeal anastomosis.
Intracorporeal ilio-ileal anastomosis with the help of an endostapler. The perineal part
Viva advancement is done and the specimen is taken out.
And the viviplasty is performed.
Through a small 5 centimeter incision, the term loop of ileum and ureter is broken off and a conduit is formed. So that is quite easy to do. Sometimes, I don't know, I've still got time. You can do some extended resections, but only the seminal vesicle is involved. So you can just take isolated seminal vesicle excisions out as well. So once you fill the anterior dissection goes in front of the seminal vesicles. Both the mass difference are cut. And keep on dissecting down to the pelvic floor. So here doing an exentration would be too much. If you think it's just a positive CRM itself with no involvement of the bladder. So you do an intersphincter dissection from here. And probably once you finish it there, you could do an intersphincter dissection and a Hansen coloanal anastomosis. Okay. So thanks, man. I think I think there's a lot of things can be done.
3 o'clock. Yes. Dr. Avnish, excellent presentation. I think almost we finished on time. Just one question just before we what percentage of the patient in Indian context needs a splenic flexure mobilization? Because most of the time we can get away sometime 30 to 40% without doing a splenic flexure mobilization and able to do the anastomosis. So what's your experience and what's the message you want to give it to us?
Thanks, Dr. Dixit. Yeah, it looks like sometimes the sigmoid is very redundant, but as you do more and more of these, sometimes I actually feel now mobilizing the splenic flexure is always a good idea. Because I think most of the tumors that we have are very low rectal tumors. So suppose if you have a problem with anastomosis and you want to do pull through or intersphincteric dissection, you should have enough length. Mobilizing the splenic flexure towards the end, I find it a bit tricky. And for higher tumors as well, probably you take a lot of column. You have to take at least 10 centimeters. But I agree, sometimes in some but what I don't know is splenic flexure mobilization. But I think both things are okay. But I am trying to think the leak rates are definitely going down with mobilizing of all of the splenic flexures. It takes time. I know you're a busy surgeon, you have to do 2 or 3 in a day. So sometimes it's easier if not to mobilize the splenic flexure. But in my practice, I do it in all patients.
Excellent. I think if there is no questions in the chat box, I think over to Dr. Vivek, I think, for your conclusion remarks.
Thank you so much, everyone. Thank you so much, speakers and chairpersons, for conducting such a nice session. We learned a lot. Wonderful talks by Professor Liu, Professor Tang, Professor Saklani. I love the background of Professor Tang, like sitting in the theater and presenting. So that is good. And thank you, Dr. Dixit, Dr. Chawla, and Dr. Neeraj for taking out time and conducting this session. So we are in